Antiarrhythmic drugs. This slide shows the Vaughan-Williams classification system for antiarrhythmic drugs. This system classifies antiarrhythmic drugs based on the channels that they block in the heart and the effects that the drugs have on the cardiac action potential. This tends to be a confusing system to learn as a medical student. It would be much easier if the drugs were divided such that one class worked for atrial fibrillation and another class worked for ventricular tachycardia. Unfortunately, that's not the case, and the Vaughan-Williams classification system, which was put in place many years ago, is still in use today. So by this system, the class 1 drugs are drugs that block sodium channels, and they are subdivided into 3 groups: the 1A drugs, the 1B drugs, and the 1C drugs. The class 2 drugs are beta blockers, which you may be familiar with from the treatment of hypertension. These drugs also have antiarrhythmic properties. The class 3 drugs are drugs that block potassium channels. And then finally, the class 4 drugs are drugs that block calcium channels. And we'll talk about all of these in this module now. First, let me give you some general principles so you have a clear picture in your mind of when we use these drugs. Antiarrhythmic drugs are used to suppress arrhythmias. This means that we use them to prevent the formation of aberrant electrical impulses in the heart. Unfortunately, most of these drugs also cause arrhythmias, so they may suppress one arrhythmia but cause another one. For this reason, most of these drugs are associated with cardiac arrest and death. For this reason, you won't see these drugs used very commonly. We restrict their use in general to dangerous arrhythmias and also recurrent, highly symptomatic arrhythmias. 2 situations where you will commonly see these drugs used is persistent recurrent ventricular tachycardia and recurrent atrial fibrillation. This shows an EKG strip of ventricular tachycardia. This is a life-threatening rhythm. It can degenerate into ventricular fibrillation and cardiac arrest. So patients who develop this arrhythmia are often placed on antiarrhythmic drugs to prevent ventricular tachycardia from occurring. In the bottom left side of the screen is an EKG showing rapid atrial fibrillation. This arrhythmia is also sometimes very symptomatic. Many patients feel palpitations, they can feel tired and short of breath. So when that happens, we will often use an antiarrhythmic drug to try and suppress atrial fibrillation and keep the patient in sinus rhythm. The mechanisms by which all of these drugs work is via slowing cardiac electrical activity in some manner. As I told you before, the class 1 drugs block sodium channels and the class 3 drugs block potassium channels. These drugs primarily exert their effects in the atrial and ventricular myocytes. Those myocytes have an action potential that looks like what I've drawn at the bottom of the screen here. This is the action potential that will be modified by the class 1 and 3 drugs. The class 2 and 4 drugs, which are beta blockers and calcium channel blockers, exert their effects in the sinus and AV node. This is a depiction of what the sinus and AV node action potential looks like, and this is the action potential that's going to be modified by the class 2 and class 4 drugs. This slide depicts the myocyte action potential. This is the action potential that occurs in atrial and ventricular myocytes, and I discussed this in much greater detail in the video on cardiac action potentials. But by way of brief review, these myocytes are at minus 85 millivolts at rest. When they depolarize, they enter phase 0, where the voltage quickly rises. This phase is determined by sodium channels, which open and allow sodium to rush in the cell. They then move through phases 1, 2, and 3, all of which involve potassium channels opening and allowing potassium to flow out of the cell and bring the voltage back down to minus 85 millivolts. Now, this action potential shows the change in membrane potential across a single myocyte. The EKG, on the other hand, shows the change in electrical activity across hundreds and thousands of myocytes. However, the two shapes are very closely related. The time it takes for a single myocyte to go through phase 0 is the time it takes for that myocyte to depolarize. That is represented on the surface EKG by the duration of the QRS complex. In other words, phase 0 is the depolarization phase of a single myocyte. The QRS is the depolarization of hundreds and thousands of myocytes. However, if sodium channels are blocked by an antiarrhythmic drug and phase 0 takes longer to occur, that can result in a stretching or a lengthening of the QRS complex on the surface EKG. And that's a very important concept for you to appreciate. On the other hand, the time it takes to go through phase 0, phase 1, phase 2, and phase 3, the entire time it takes for depolarization and repolarization is represented on the surface EKG by the QT interval. The time it takes for depolarization and repolarization is from the start of phase 0 to the end of phase 3. On the surface EKG, that's shown as the start of the QRS complex and the end of the T wave. So drugs that block the potassium channels will tend to lengthen phases 1, 2, and 3. This will tend to prolong the QT interval on the surface EKG, and that's the second very important principle you need to appreciate about the myocyte action potential as it relates to antiarrhythmic drugs. Just to make this point very clear, because it's critical that you understand this concept, here's an example of what happens when you block sodium channels in the ventricular and atrial myocytes. This is a normal action potential on the left side of the screen with a normal QRS complex. When you block the sodium channels, you will slow phase zero of the action potential, and on the surface EKG, that can result in a prolongation of the QRS complex. In contrast, when you block potassium channels, the normal action potential changes such that repolarization is prolonged. That's because you are obstructing the outflow of potassium ions from the cells, and on the surface EKG, that can result in a prolongation of the QT interval. Two other important terms here: the time it takes for the action potential to begin and end and return the voltage to minus 85 millivolts is called the action potential duration. There is another important time length in the action potential that's called the effective refractory period. This is the time during which the cell cannot undergo another depolarization. So it turns out that the voltage doesn't have to go all the way back down to minus 85 millivolts for the cell to be able to depolarize again. At a point about midway through phase 3, the cell can, if triggered, depolarize again. And the time to reach this point is called the effective refractory period. And both of these concepts will be important when we talk about the antiarrhythmic drugs. Now we're ready to start our discussion of specific class 1 drugs. And as I told you before, all of the class 1 drugs block sodium channels. And anytime sodium channels are blocked, phase 0 of the action potential can become prolonged, and that can result in prolongation of the QRS complex on the surface EKG. Some of these drugs also block potassium channels, and as we talked about before, that can lead to prolongation of the QT interval. These drugs also can prolong the action potential duration and the effective refractory period, and these effects both occur because sodium channels are blocked and therefore depolarization takes longer to occur. This slide is the most important slide for you to remember in terms of the class 1 drugs. It shows the effects on the resting action potential of the 3 different groups of class 1 drugs. In each picture, the blue line is a normal action potential and the red line is an action potential after administration of one of the types of class 1 drugs. And after what we've talked about in the last few slides, this slide should make sense to you. Let's start by going through the 1C drugs first. These drugs are pure sodium channel blockers, so they will lengthen the time it takes for phase 0 to occur. That can result in an increase in the QRS duration on the surface EKG. They do not have a significant effect on the QT interval because the time it takes for depolarization and repolarization to occur is not significantly different from normal. Therefore, they also do not change the action potential duration in a significant manner. Next, let's talk about the 1A drugs. These drugs also block sodium channels and increase the time it takes for phase 0 to occur. This results in a lengthening of the QRS complex on the surface EKG. These drugs also have some potassium channel blocking effects, therefore they stretch out the action potential, and that will increase the QT length on the surface EKG. These drugs also therefore increase the action potential duration and the effective refractory period. The 1B drugs are somewhat unusual. We'll talk about them in a few slides. They slightly shrink the action potential duration and the effective refractory period. This can result in a slight shrinking of the QT interval, and they have no significant effect on the QRS complex in the resting action potential. Now let's talk about each of the groups of class 1 drugs in more detail. We'll begin with the class 1A drugs. There are 2 important drugs in this class, quinidine and procainamide. And remember that this is the depiction of their effects on the action potential. So these drugs can prolong the QRS complex on the surface EKG, and that's because they block sodium channels and they cause phase 0 of the action potential to take longer to occur. They also have some potassium channel blocking effect. This means that the action potential duration will increase, and this means that they can also prolong the QT by blocking the outflow of potassium from myocytes. Quinidine is an oral drug. It used to be used a lot years ago. It's not used very much anymore. It can decrease the recurrence rate of atrial fibrillation. It's been associated with increased mortality, and we now have better drugs than quinidine, so it's not used much in the modern era. Procainamide used to be available as an oral drug, but now it's only used as an intravenous drug. Its main use is that it slows conduction in accessory pathways in patients with the Wolff-Parkinson-White syndrome, so it can be used in arrhythmias associated with bypass tracts in the WPW syndrome. Procainamide can cause an unusual side effect. It's associated with drug-induced lupus. This really doesn't happen in the modern era. We only give procainamide intravenously for a short period of time. But decades ago, procainamide was given orally for long periods of time, and some patients would develop drug-induced lupus. This syndrome is also associated with some other drugs like isoniazid or INH, which is a tuberculosis drug, and hydralazine, which is a rarely used antihypertensive. Patients who develop drug-induced lupus often develop a rash and arthritis and anemia. This is all similar to traditional lupus. Their ANA or anti-nuclear antibody test can be positive just like in traditional lupus, but a unique feature of drug-induced lupus is the presence of antihistone antibodies. These antibodies are rarely seen in traditional lupus. They're much more commonly associated with drug-induced lupus, and this syndrome resolves when you stop the drug. The important class 1B drugs are lidocaine and mexilotine. This shows what they do to the action potential duration. They have little to no effect on the QRS complex at normal heart rates. That's because they don't affect phase 0 very much. Most of their effects are exerted at fast heart rates. We'll talk more about that in a minute. They can slightly decrease the QT interval, although this effect is minimal. And these drugs are famous for having the least effect on the action potential of all of the class 1 drugs. Most of the binding of the 1B drugs occurs when myocytes are in the depolarized state. If you look at the action potential at the bottom of the screen, this is the depolarized state when the membrane potential has become positive, and this is where the class 1B drugs like to bind. When there is ischemia, more myocytes are found in the depolarized state. The myocytes become damaged and they can't maintain their negative membrane potential, so they become depolarized, and that's where the 1B drugs are effective. This makes them very useful drugs in ischemic arrhythmias when there's lots of ischemic tissue present. Another feature of these drugs is that they rapidly unbind when myocytes exit the depolarized state. This means that these drugs have less effect at slow heart rates. There will be little drug bound by the time the next heartbeat comes along. In other words, when the myocyte exits the depolarized state, the drug will quickly unbind, and when the next heartbeat occurs, there will be little drug bound to the sodium channels. These drugs are more effective when the heart rate is faster. This is because there is less time for the drug to unbind before the sodium channel opens again. For this reason, these drugs are very useful in ischemic ventricular tachycardia. First of all, there's ischemic tissue, which we talked about is beneficial to the utility of these drugs. In addition, there are fast heart rates and lots of depolarized sodium channels. All of this makes this the ideal situation to use the 1B drugs. One of the ways that lidocaine can terminate arrhythmias is by abolishing reentry. Reentry is a mechanism of arrhythmia generation in myocyte injury, and I talk about it in more detail in the module on action potentials. I'll just briefly review here how reentry occurs and how lidocaine abolishes it. So in reentry, you have pathways in the cardiac electrical system that have different conducting abilities. So let's imagine there's one pathway labeled A here that can conduct electricity normally like this. Now let's imagine there's another pathway labeled B which is blocked going forward. This means that electrical activity cannot conduct in the forward manner through pathway B. What can then happen is that the electrical activity that goes through pathway A can come back and up around. This is called reentry, and this can generate a circuit which can lead to arrhythmias. What lidocaine does is convert that unidirectional block, that block that is only in the forward direction, into a bidirectional block so that electrical activity cannot go in either direction. This will abolish the reentry because a circuit cannot be developed in which electricity goes around in a loop. And that's one of the mechanisms by which lidocaine can terminate arrhythmias. Lidocaine, you may know, is also a local anesthetic. It can be used to block sodium channels in peripheral nerves so that patients don't feel pain. Mexilotine is an oral drug only, so it's not used in this manner. Mexilotine is basically an oral version of lidocaine. Both of these drugs can potentially cause CNS stimulation as a side effect by blocking sodium channels in central nervous system neurons. Patients can develop tremor and agitation. Tremor in a patient taking oral mexilotine chronically is a sign of toxicity. And both of these drugs can potentially cause cardiovascular side effects from excessive block of sodium channels. Basically, if you block too many sodium channels, the heart will stop conducting electricity and will stop contracting normally. So these patients can develop bradycardia and heart block and hypotension. Finally, let's discuss the class 1C group of drugs. There are two drugs in this class, flecainide and propafenone. Both of them block open sodium channels and have very slow unbinding. As a result, they dramatically shift phase 0 of the cardiac action potential, and the QRS can markedly prolong on these drugs. If your QRS gets too long, you can go into cardiac arrest, and therefore these drugs have limited use due to concerns of toxicity, especially pro-arrhythmic effects. This is a good point to pause and mention the CAST trial. This was a landmark clinical trial in cardiology of antiarrhythmic drugs conducted many decades ago. CAST stands for Cardiac Arrhythmia Suppression Trial. This trial was conducted to test the suppression hypothesis. At the time, it was believed that asymptomatic arrhythmias were dangerous. In other words, many patients had short runs of asymptomatic arrhythmias, and the thinking was that those runs could continue in some cases and lead to death. So the thought was that suppressing those arrhythmias with drugs would improve outcomes among patients. Patients enrolled in this trial had asymptomatic arrhythmias after myocardial infarction, and they were treated with two 1C antiarrhythmics, enconide and flecainide. Patients taking the drugs had less arrhythmias as expected. However, a surprise finding was a 3.6-fold increased risk of arrhythmic death. In other words, the patients had less arrhythmias, but the arrhythmias they did have were more deadly. As a result of this trial, there was a major decrease in the use of antiarrhythmic drugs, and we now only use them when there's a compelling indication because we are aware that they carry an increased risk of death. Back to our discussion of the 1C drugs flecainide and propafenone. These drugs are only used in patients with structurally normal hearts. That's because clinical trials like the CAST trial showed significantly increased mortality when patients with cardiomyopathy or other structural heart disease took these medications. Their main niche is that they're effective in reducing the recurrence of atrial fibrillation, so you can use them in patients with highly symptomatic recurrent atrial fibrillation who have structurally normal hearts. When you administer the drugs, you must monitor for QRS prolongation. A prolonged QRS means the patient is at risk of cardiac arrest, and this is a real-life implication of the changes in the action potential we've been discussing with the Class 1 agents. You want to block some sodium channels, but not so many that the QRS begins to prolong. So if the patient's taking the drug and the QRS begins to prolong, it means they're not tolerating that dose, and you need to modify the therapy. Another feature of these drugs is something known as use dependence, so let's talk about what that means now. Sodium channels in cardiac myocytes fluctuate between three different states. They can be in the resting state, the open state, or the inactivated state. If you look at this action potential at the bottom of the screen, the open sodium channel state occurs during phase 0 of the action potential. The inactive state occurs when the membrane voltage is positive, and then the resting state occurs when the action potential is completed. Antiarrhythmics can bind more in certain states, and the Class 1 drugs bind best in the open or inactivated states. In other words, states where the sodium channel is in use. Therefore, these drugs are said to exhibit use dependence. Drugs that exhibit use dependence have more effect at faster heart rates. To understand this, let's look at the two EKG strips shown on the screen. The top EKG strip shows a patient who has bradycardia. The times where the sodium channel is in use are highlighted in blue. This is when the sodium channel is open or inactive and myocytes are depolarizing or in the inactivated state. The times where there's no blue shown, the sodium channel is in the resting state. And you can see that if a patient is bradycardic, there's some blue, but there's also lots of periods where there is no blue present. The bottom of the screen is a patient who is tachycardic. You can now see that the sodium channels are spending most of their time in the open or inactivated state. This means that drugs which exhibit use dependence will have more effect in the tachycardic state when the sodium channels spend more time in the open or inactivated state. So I've summarized this point at the top of this slide. Use-dependent drugs have more binding at fast heart rates, and all of the Class 1 drugs have some use dependence, but this is seen most frequently with the 1C drugs, and this has a practical, real-life implication among cardiology patients. Patients who are taking flecainide or propafenone, the 1C drugs that have marked use dependence, are at risk for toxicity and QRS prolongation at high heart rates. For that reason, when I start one of the patients in my practice on one of these drugs, I send them for a stress test while they're taking the drug. I want them to get their heart rate up to a very high heart rate, and I want to see if their QRS prolongs at high heart rates. If it does not prolong, then I think they are safe on the drug. On the other hand, if their QRS prolongs at high heart rates when the sodium channels are in use, I know that the patient is at risk for toxicity, and I need to either stop the drug or modify the dose. Now let's talk about the Class 3 antiarrhythmics. Drugs in this class include amiodarone, sotalol, dofetilide, and ibutylide. These drugs block potassium channels in cardiac myocytes, and that will delay repolarization and lengthen the action potential duration. There's no significant effect on the QRS interval, and that's because phase 0 is unchanged by these drugs. However, the QT interval can become prolonged, and that's by the mechanism we discussed previously. Anytime the action potential duration is lengthened, the QT interval can potentially prolong. The action potential duration and the effective refractory period are increased by drugs in this class. The feared complication of QT prolongation by Class 3 antiarrhythmics is an arrhythmia called torsade de pointes that can result in cardiac arrest. This is an EKG tracing showing torsade de pointes on the screen. You can see that the QRS intervals are large, and then they shrink, and then they become large again. The name torsade de pointes means twisting of the points, and it gets its name because of the shape of this arrhythmia. And the Class 3 drugs can prolong the QT and cause this. So can the Class 1A drugs. Remember that when we discussed those drugs, they not only shift phase 0 narrow of the action potential, they also lengthen the action potential duration by blocking some potassium channels, and therefore they can prolong the QT interval. Let's begin our discussion of class 3 drugs by talking about amiodarone, which is the drug in this class that is most frequently used clinically. It's a class 3 drug, so it blocks potassium channels and it can prolong the QT interval. However, it has the lowest incidence of torsades de pointes of all the class 3 drugs, and it's the safest of the class 3 drugs in terms of that arrhythmia. What you need to always remember about amiodarone is that it also has class 1, 2, and 4 effects. It has class 1 effects, it can prolong the QRS interval. It also has class 2 and 4 effects, it can slow the heart rate and delay AV conduction. If you ever read a description in a board question of an antiarrhythmic that prolongs the QRS, prolongs the QT, and slows the heart rate, they are probably talking about amiodarone. It has the most diverse effects of any of the antiarrhythmics. The reason it's used commonly in clinical practice is because it's very effective. It suppresses atrial fibrillation and keeps patients in sinus rhythm. It's also useful for suppressing ventricular tachycardia. Amiodarone is highly lipid soluble, therefore it accumulates in lots of tissues, including the liver, the lungs, the skin, and other tissues, and as we'll see in a minute, this is the reason for many of its adverse effects. It has a very long half-life, about 58 days. Once a patient is loaded on amiodarone and they have reached steady state, it takes a very long time for the drug to wash out of their system. Because it's lipid soluble, however, it is safe in renal disease. It is primarily biliary excreted and not excreted via the kidneys. Now you would think that because of all the effects amiodarone can have on the QRS interval and the QT interval and the heart rate and AV node conduction, that most of its adverse effects would be related to problems with electrical conduction in the heart. However, that turns out to not be the case. Amiodarone rarely causes problems with electrical conduction in the heart. Most of its side effects are related to the fact that it accumulates in so many different tissues in the body. We'll talk about all those side effects in a minute. Now, all of these side effects are less likely at lower dosages, and the risk accumulates over time. So in other words, the longer you take amiodarone, the more likely you are to develop adverse effects. For this reason, young patients who are placed on indefinite therapy are at the greatest risk, and we rarely use amiodarone in young patients because they may need it for the rest of their lives and they have a lot of years left ahead of them. The place you will often see amiodarone used is in older patients. If a patient is 80 or 90 years old, it's unlikely that they will live long enough to develop toxicity from amiodarone. So now let's talk about all those diverse side effects of amiodarone. Amiodarone contains iodine. This is amiodarone's molecular structure shown on the screen. You can see that it contains iodine atoms as part of the molecule. If you ever forget this, the reason the word IOD is in amiodarone is because it contains iodine. And you may know that iodine is very important for synthesis of thyroid hormone, so amiodarone can cause both hyper and hypothyroidism. And I talk about the mechanism of these two adverse effects of amiodarone in detail in the thyroid modules in the endocrinology section. Amiodarone can also accumulate in the liver, and therefore it can cause increased LFTs. This is usually asymptomatic and mild. However, the drug is stopped if the elevation is marked. Amiodarone can also accumulate in the skin, and this results in skin sensitivity to sun. Patients on amiodarone easily sunburn. We say that they are photosensitive, and I've shown you a picture of a sunburned man here to help remind you of this adverse effect. Now, although photosensitivity is the most common skin effect of amiodarone, a less common effect is a blue-gray discoloration of the skin that sometimes occurs, especially if patients take high dosages of amiodarone. This is sometimes called the blue man syndrome, and it's most prominent in the face. You can Google the blue man syndrome in amiodarone, and you'll find lots of examples of this. In addition, some patients on amiodarone develop corneal deposits. This is because amiodarone is secreted by the lacrimal glands, and it accumulates on the corneal surface. It has a very unique appearance. It looks like cat whiskers. It's sometimes described as having a whorl with little whiskers coming off from it. You can also Google this and find lots of examples. It does not usually cause vision problems. It's just a sign of patients taking the drug. It's seen in many patients on chronic therapy, and you don't necessarily have to stop the drug just because of this finding in the eye. The feared complication of amiodarone comes from its accumulation in lung tissue. Amiodarone can cause pulmonary fibrosis. This is the most common cause of death from amiodarone. If you do a biopsy of lung tissue on patients who have amiodarone lung toxicity, you will see foamy macrophages in the air spaces. Those macrophages are filled with amiodarone and phospholipids. Remember, amiodarone is lipid soluble, so it's often found in association with phospholipids. On chest x-ray, you see a honeycombing pattern, as I've shown you in this x-ray on the screen here. So now that you understand the adverse effects of amiodarone, you can understand the diagnostic testing that's often done when we start a patient on this drug. A chest x-ray and pulmonary function tests are often ordered to establish baseline lung function. Thyroid function tests and liver function tests are also ordered to establish a baseline that we can compare to after patients begin the drug. Now let's talk about some of the other class 3 antiarrhythmics. Sotalol and dofetilide are class 3 drugs. They block potassium channels. Both of these drugs can significantly prolong the QT interval, and they carry a significant risk of torsade de Pointes. This has practical implications. When patients are being started on one of these drugs, we often admit them to the hospital so that their heart rhythm can be monitored on telemetry and the QT segment can be checked each day. After about 2 or 3 days on the drugs, if the QT segment is not prolonged and the heart monitoring shows no evidence of torsade de Pointes, they can be discharged home. But the highest risk is in the first few days, and therefore that's when we usually monitor them in the hospital. Sotalol also has beta blocking properties. That's why it ends in alol like other beta blockers. Both of these drugs can be used in patients with cardiomyopathy. That's their niche. When patients have especially atrial fibrillation and a depressed ejection fraction, these are the drugs that we usually go to. And both of these drugs carry a unique feature called reverse use dependence, which is the opposite of use dependence that we talked about before. Reverse use dependence has to do with the fact that potassium channels also fluctuate between 3 different states, just like sodium channels. The class 3 drugs, sotalol and dofetilide, bind best in the resting state. Therefore, these drugs exhibit what's known as reverse use dependence, meaning they exert their greatest effects when the channel is not in use. This means that these drugs have more effect in patients who are bradycardic. To understand this, let's once again look at our bradycardic rhythm at the top of the screen. I've highlighted in blue the portions of the EKG where the potassium channel is resting and not in use. And you can see that in the bradycardic patient, the potassium channel spends a significant amount of time in the resting state as opposed to the open and inactive state. When the patient becomes tachycardic, the amount of time the channel spends in the resting state becomes smaller. This means that patients on these drugs are at greater risk for toxicity when their heart rate gets very slow and they are bradycardic and the potassium channel spends more time in the resting state. So reverse use dependence means more binding at slow heart rates, and the practical implication of this is that bradycardia in patients on sotalol and dofetilide can be dangerous. The QT interval can prolong and there's an increased risk of torsade de Pointes. Sotalol and dofetilide are commonly used in patients with atrial fibrillation. A typical case is a patient who has recurrent episodes of symptomatic atrial fibrillation when not taking one of these drugs. We will then start sotalol or dofetilide. We will then perform a procedure called a cardioversion, which I'll talk about in a minute, to restore sinus rhythm, and then sinus rhythm will persist on therapy instead of having the patient go back into AFib like they were doing before. And this is the way many other antiarrhythmics are also used for recurrent symptomatic atrial fibrillation. Drugs like amiodarone, propafenone, and flecainide are all also used in this manner. The last class 3 antiarrhythmic agent we'll discuss is ibutilide. This is an intravenous drug with a very short half-life of about 2 to 12 hours, and its main use is for something called chemical cardioversion. So let's talk about what that is now. Cardioversion is the termination of an arrhythmia. Sometimes this is done when patients are unstable. You may have seen this done in movies or on TV where a patient is unstable and the doctor places the pads on the chest and shocks the patient and they go back into sinus rhythm. In actual practice, this is more commonly done under much more stable settings, including when patients have atrial fibrillation or atrial flutter. With these arrhythmias, patients are usually not unstable, but they may be uncomfortable from the arrhythmia, and therefore we want to restore sinus rhythm to make them feel better. In these more stable situations, there are 2 options for cardioversion. The first is to perform what's known as an electrical cardioversion. This involves use of a defibrillator, and it also requires sedation. It's very uncomfortable when you deliver a shock to the patient's chest, so you need to sedate them and put them to sleep, and then you administer a shock to the chest. What this will do is depolarize all the conducting cells in the heart, and the first cells to wake up and begin repolarizing again are usually the cells of the sinus node. Thus, this will convert an arrhythmia like atrial fibrillation into sinus rhythm. Another option, an alternative to electrical cardioversion, is called chemical cardioversion, and this involves using ibutilide. Ibutilide will also convert atrial fibrillation and atrial flutter into sinus rhythm in many cases. The advantage is that no sedation is required because you're not administering a shock. However, the major downside is that ibutilide can cause torsade de Pointes, just like all of the class 3 agents. For this reason, patients need to be monitored for several hours after the cardioversion with ibutilide because there's a risk of torsade. And because of the need to monitor patients for several hours, chemical cardioversion is done much less commonly than electrical cardioversion. After an electrical cardioversion, when the patient wakes up, they can go home safely. Next, let's talk about beta blockers, which are class 2 antiarrhythmics. You may be familiar with the use of beta blockers to treat hypertension, but they can also be used when hypertension is not a problem solely for their antiarrhythmic properties. The main effect of beta blockers is on the pacemaker cells in the SA and AV node. This is a drawing of the action potential of a pacemaker cell. I discussed this in detail in the video on cardiac action potentials. What beta blockers do is decrease the slope of phase 4 and prolong repolarization in phase 3. Phase 4 of the pacemaker action potential is the funny current. That's the slow, steady depolarization of SA nodal pacemaker cells. When they reach about minus 40 millivolts, those cells will depolarize, and in the SA node, this will result in generation of a heartbeat. Beta blockers decrease the slope of phase 4 so that it takes longer for SA nodal cells to reach minus 40 millivolts. This means they will depolarize less frequently, and this will result in a slowing of the heart rate. Beta blockers also cause phase 3 repolarization to take longer. They cause phase 3 to look more like this. This makes it take longer for AV nodal cells to depolarize and repolarize, and thus they slow conduction in the AV node. To make this more clear, here's a drawing of the pacemaker action potential. The blue line is a normal action potential. The red line is an action potential after administration of a beta blocker. You can see that phase 4 has a lower slope and is prolonged. This means it takes longer for SA nodal pacemaker cells to reach the depolarization threshold. Thus, they will depolarize less frequently, and there will be a slower heart rate on a beta blocker. In addition, repolarization in phase 3 is prolonged. This means that it will take longer for AV nodal cells to go through the entire process of depolarization and repolarization. This will result in a slowing of the conduction velocity through the AV node, and it can result in a prolongation of the PR interval. Class 4